Hello everyone and welcome to our module on demyelinating diseases. So shown on this slide are the important demyelinating diseases to become familiar with as a medical student, and the most important one is multiple sclerosis, which I talk about in its own video. But all these other disorders listed here are also demyelinating diseases, and we'll talk about all of them in this video, except for these last two here. I've included them on this list for completeness sake, but these are lysosomal storage diseases, and I talk about these disorders in their own video in the biochemistry section. So we'll start by talking about Guillain-Barré syndrome, which is a peripheral nerve disorder, and the key word is peripheral. So this affects nerves outside of the brain and spinal cord, so very different from multiple sclerosis, which is a central nervous system disorder. Guillain-Barré syndrome is a form of acute inflammatory demyelinating radiculopathy, and so all the words of this term are important. It's acute in its onset, the symptoms develop rapidly. It's an inflammatory condition that involves demyelination and abnormal function of nerves. That's radiculopathy. A key thing to understand about this disorder is that Schwann cells are destroyed by the immune system. So Schwann cells are the cells that produce myelin in the peripheral nervous system. So hopefully it makes sense to you that these would be destroyed in a peripheral demyelinating disorder. And the exact underlying cause of Guillain-Barré syndrome is not well understood, but it probably involves molecular mimicry. As we'll see in a minute, this syndrome is usually triggered by some immune stimulus like a viral infection that generates an immune response, and that probably leads to an immune response that cross-reacts with host tissues, and that's what leads to this disorder. So the nerve fibers that are affected in Guillain-Barré syndrome are peripheral myelinated nerves. So this includes somatic motor fibers, which means the nerve fibers that supply muscles in our body. And so when you have damage to these fibers, that leads to flaccid paralysis, lower motor neuron type muscle paralysis. Also in Guillain-Barré syndrome, you have damage to peripheral sensory fibers. So this can lead to symptoms like paresthesias and numbness, which we'll talk about in a minute. And then finally, preganglionic autonomic nerve fibers are myelinated fibers. So they get damaged in Guillain-Barré syndrome as well. And this can lead to autonomic instability with problems related to heart rate and things like that. So as I mentioned earlier, Guillain-Barré syndrome has an acute onset with symptoms that occur over days to weeks. And the dominant clinical feature of this disorder is ascending muscle weakness. So this means lower motor neuron flaccid paralysis and weakness that starts in the legs and spreads upward over the body. Importantly, this is a peripheral nerve problem, meaning it affects lower motor neurons. So you see lower motor neuron signs, which include flaccid paralysis and decrease in deep tendon reflexes. And I talk in detail about lower versus upper motor neuron signs in other videos. As the symptoms ascend over the body, you can see respiratory failure from respiratory muscle weakness. This occurs in up to 30% of patients. And sometimes the symptoms ascend so high that you get facial muscle weakness. This occurs in about 50% of patients. There are sensory symptoms associated with Guillain-Barré syndrome, but these are mild. These are usually things like paresthesias, meaning pins and needles, or symptoms like pain. And left untreated, if the patient survives and doesn't die from respiratory failure, the symptoms of this condition usually resolve on their own over weeks to months. So I mentioned this earlier, but peripheral autonomic neurons can be affected in Guillain-Barré syndrome, and this can lead to autonomic dysfunction. This is seen in about 70% of patients. So this includes things like tachycardia, urinary retention, hyper or hypotension. You can see arrhythmias in this disorder and even sudden cardiac death. There can be GI ileus and there can be loss of sweating. All these things are related to loss of function of autonomic neurons. And as I said on the last slide, the symptoms of this disorder slowly resolve over weeks to months unless patients die, and the cause of death is either severe autonomic dysfunction like cardiac arrhythmias or respiratory failure. We don't know exactly what causes Guillain-Barré syndrome, but it's been well borne out in clinical studies that this condition is associated with infection. No definite causal link, no definite causal infection has been identified, but in the majority of cases of this condition, 1 to 4 weeks before the onset of Guillain-Barré syndrome, the patient has some type of infection that is believed to trigger the immune response. This doesn't have a lot of clinical relevance. The causative agent is not typically looked for, but especially for your step 1 exam, you want to be aware of the association between infection and Guillain-Barré syndrome. There are many different infectious agents that have been tied to this syndrome, but some of the important ones to know are, first of all, Campylobacter jejuni. It's a classic trigger for Guillain-Barré. This is a GI infection. It leads to bloody diarrhea, so a patient who has this condition 1 to 4 weeks later could develop neurologic symptoms of Guillain-Barré syndrome. Cytomegalovirus infection has also been well described as linked to Guillain-Barré syndrome. Usually infections with this virus are asymptomatic, but arise in CMV antibodies has been shown in many patients who go on to develop Guillain-Barré syndrome. And then Zika virus is a rare mosquito-transmitted infection, but there have been outbreaks around the world of this virus that have been closely tied to GBS cases. So in parts of the world where lots of people develop Zika virus, they have later seen a rise in cases of Guillain-Barré syndrome believed to be linked to the Zika virus infection. The diagnosis of Guillain-Barré syndrome is usually made clinically when a patient presents a few weeks after some type of infection with typical ascending motor weakness. But one test that's usually done is a lumbar puncture, and that's because there are CSF findings that support the diagnosis of Guillain-Barré and also rule out other conditions. The classic finding in Guillain-Barré syndrome is an elevated protein count in the CSF, but a normal cell count. This is referred to as albuminocytologic dissociation, and it gets this name because there's a dissociation between the cell count and the protein level. Usually when you have elevated protein, you also have elevated white cells indicating inflammation. Guillain-Barré syndrome is unusual in that there's demyelination, which allows protein to leak into the CSF, but there isn't a significant amount of inflammation, so the white cell count is usually normal. And this is referred to as albuminocytologic dissociation. And then usually no other testing is done beyond a lumbar puncture, but in some cases where the diagnosis isn't clear, there are nerve conduction studies that can be done to show abnormal conduction in axons in peripheral nerves. And so some people use the mnemonic, the 3 A's, to remember the classic features of Guillain-Barré syndrome. The 3 A's are ascending paralysis, autonomic neuropathy, and albuminocytologic dissociation. Let's talk about the treatment of Guillain-Barré syndrome. So first of all, for real life and for board exams, you have to remember that respiratory monitoring and support is critical in this disorder because one of the ways people die from Guillain-Barré is from respiratory failure. So you can monitor the vital capacity by spirometry. If this starts to go down, that can indicate impending respiratory failure. There are also devices called NIF monitors that measure the negative inspiratory force when the patient draws in a breath of air. And so both of these are often monitored, often in the hospital in patients with Guillain-Barré, because if they start to decline, that indicates the patient needs ventilatory support, either non-invasive ventilation or mechanical ventilation. Beyond respiratory support, there are 2 treatments for Guillain-Barré syndrome. The first one is called plasmapheresis. This involves hooking the patient up to a machine like what's shown in this picture here, and the way plasmapheresis works is the patient's blood is removed and then the cells are returned, but they're returned within replacement fluid. You remove the blood elements, the non-cellular elements from the blood. And the idea here is that this removes pathogenic autoantibodies, and this has been shown to improve the clinical features of Guillain-Barré syndrome. The other therapy for Guillain-Barré is IV immunoglobulins, or IVIG. This therapy involves pooled IgG antibodies from healthy donors, and you infuse these into the patient's bloodstream. And what the IgG antibodies from healthy donors do is they block Fc receptors on macrophages, and this prevents macrophages from becoming activated. In other words, it decreases the activation of macrophages and it dials down the autoimmune response that's causing Guillain-Barré syndrome. And then finally, just an important note, steroids have been studied and they are not effective in Guillain-Barré syndrome, so if you see this in a board question, this is likely a wrong answer. Okay, our next demyelinating disorder is called Charcot-Marie-Tooth disease, also known as hereditary motor and sensory neuropathy. This is a progressive hereditary peripheral nerve disorder, so let's talk about what this term means. So it's progressive, meaning it gets worse over the course of a person's lifetime. It's hereditary, meaning it's inherited. We'll talk about some of the gene mutations in a minute. And it involves peripheral nerves, especially the nerves of the legs. The usual onset of this disorder is in late childhood or adolescence, and what happens is there's defective production of nerve proteins or myelin, or both, so that there's abnormal nerve function in peripheral nerves, especially related to the legs. This leads to weakness in the legs, but also the leg muscles become wasted from lack of proper innervation. As a result, the leg muscles become very thin, like in this picture shown on the slide here, and it is said that the child or the adolescent with this disorder develops a characteristic stork-like contour of the legs. And if you Google this online, you'll see lots of examples of the stork-like appearance of the legs in Charcot-Marie-Tooth. Because the muscles of the legs and the feet are abnormal in Charcot-Marie-Tooth disorder, because there's abnormal innervation of those muscles, this usually leads to foot deformities. And there are 2 classic foot deformities seen in Charcot-Marie-Tooth. The first one is called pes cavus. This refers to a high arch, rigid foot that won't flatten. If you look down at the bottom of the slide here, this is what a normal foot should look like, and this is the foot deformity pes cavus seen in children with Charcot-Marie-Tooth. You can see that there's a high arched foot. Also, it won't flatten, it's very rigid. The other finding is called a hammer toe. This is a flexion deformity of the toes. I'll show you a picture of this in just a second. Beyond these deformities, children with this condition often have foot drop, and this leads to falls and clumsiness. The upper extremities can be affected, but they are affected less. This is mostly a disorder that involves the legs and the feet. And then there can be some sensory loss, especially in the feet, involving proprioception and vibration. So here's a picture here on the left of the stork-like appearance of the feet. Hopefully you can appreciate this. Over here on the right, this is the pes cavus arch of the foot. You can also see what a hammer toe looks like here. That's this toe that's sort of at a right angle here, sort of looks like a hammer. As I said before, this is a hereditary disorder, and it's usually passed down through families in an autosomal dominant manner. The most common subtype is Charcot-Marie-Tooth 1A or CMT1A. And the genetic cause of this subtype is a PMP22 duplication. So let me explain what I mean by this. So PMP22 stands for peripheral myelin protein 22. And as the name implies, it's a protein component of peripheral myelin sheaths. In people with the CMT1A subtype of this disorder, they have 3 copies of the PMP22 gene instead of 2. This leads to overexpression of this PMP22 protein. And this disrupts myelin formation in peripheral nerves. And so this is believed to be the genetic underlying of the most common form of Charcot-Marie-Tooth, the 1A type. Okay, moving on, our next demyelinating disorder is progressive multifocal leukoencephalopathy, or PML. This is a demyelinating disease of the central nervous system, not the peripheral nervous system like Guillain-Barré and Charcot-Marie-Tooth. The cause of this disorder is reactivation of the latent JC virus. I talk about the JC virus in videos in the infectious disease section, but it's a virus many of us are exposed to, and it can lie dormant inside the brain. And if a person becomes immunosuppressed, it can reactivate a latent infection. The virus infects oligodendrocytes, and so as you can imagine, when it reactivates, it can kill those oligodendrocytes, and that can lead to demyelination of central nervous system axons. And in order for this latent virus to reactivate, there has to be some type of immunosuppression. So this disorder is associated with various forms of immunosuppression. You can see it in patients who have lymphoma or leukemia. It's a classic central nervous system development in HIV and AIDS when the CD4 count gets very low. You can see it in patients who have solid organ transplantations who are on powerful immunosuppressant drugs. And then it's super ideal to remember that it's associated with the multiple sclerosis drug natalizumab, which I talk about in other videos. But patients who are going to take this drug for multiple sclerosis are screened for latent JC virus infection before the drug is started because there's such a risk of PML developing. So PML has a subacute onset, which means a slow onset, usually over weeks or months. The dominant feature is encephalopathy, meaning confusion. So patients will develop an altered mental status slowly over months in the setting of immunosuppression. That's what you see in PML. There can also be focal neural deficits sometimes because of demyelination. Those can be motor or sensory. The lobes of the brain that are most commonly affected are the parietal and occipital lobes, and because our visual cortex is in the occipital lobe, visual symptoms are common with PML. Patients can develop cortical blindness. They can also develop visual field defects, and I talk about all these things in videos in the ophthalmology section. The MRI findings in PML are basically just patchy, multifocal lesions without mass effect. This is a picture of what it can look like on the slide here. These white regions indicated by the arrows are regions of demyelination in the central nervous system, and there's no mass effect because these areas just represent demyelination. They aren't masses growing in the brain. The diagnosis is made by identifying JC virus DNA. Usually this is done from a CSF sample from lumbar puncture, although in rare cases a brain biopsy can be done. And this is usually a fatal condition. That's why it's so feared as a complication of natalizumab for multiple sclerosis. Really, the only treatment is to resolve the immunosuppression and reconstitute the immune system. Okay, our next demyelinating disorder is post-infectious encephalomyelitis, also known as ADEM or acute disseminated encephalomyelitis. This is an acute onset condition. It usually develops over weeks, and it involves multifocal neurologic symptoms. We'll talk about those symptoms in just a minute. It's an inflammatory condition that leads to central demyelination. So we're talking about axons of the brain and spinal cord, not peripheral demyelination like some of the other disorders we talked about in this video. Patients with this disorder develop altered mental status. They also develop upper motor neuron type weakness because remember, we're demyelinating central axons, which are upper motor neurons. Often these patients rapidly deteriorate and have to be hospitalized, and usually this disorder follows either an infection or a vaccination. It's been reported after children have varicella or measles. This is a child with chickenpox, which is varicella infection shown on the slide here. It's also been reported after people receive vaccines like the rabies vaccine or the smallpox vaccine. The mean onset of symptoms is 26 days after exposure to one of these vaccines or infection. And the probable cause is molecular mimicry. There's probably something in these vaccines and infections that in a susceptible individual triggers an immune response that leads to this disorder. So in a board question, this disorder is going to be either a child or an adult who had one of those infections or vaccinations, and then a few weeks later develops encephalopathy, which is confusion followed by upper motor neuron type weakness. CSF findings are variable. Usually you see lymphocytes with elevated protein, but there isn't really a classic CSF finding for this disorder. The MRI findings are just bilateral asymmetric lesions. This is a picture of what they can look like on the slide here. These white spots are evidence of ADM, but there's nothing about the MRI that's particularly striking that's going to jump out at you. The treatment is with steroids, usually methylprednisolone. If there's an inadequate response, some of those treatments we talked about for Guillain-Barré can be tried, like IVIG or plasma exchange, which is another name for plasmapheresis. Okay, our last disorder for this video is the osmotic demyelination syndrome, also known as central pontine myelinolysis. In this condition, there's massive demyelination of axons in the pons. That's why it's sometimes called central pontine myelinolysis. And the cause of this disorder is rapid osmotic changes in the plasma. The classic cause of osmotic demyelination syndrome is over-rapid correction of hyponatremia. In the renal section, I talk in detail about the treatment of hyponatremia, but when a patient presents with a low sodium, you cannot correct that too rapidly. If you do, it will lead to this osmotic demyelination syndrome. And there's a mnemonic that's been used for a long time to remember this, and the mnemonic goes from low to high, your pons will die. And this means if you correct hyponatremia, meaning low sodium, too quickly, your pons will die and you will get this syndrome. There's a second half to this mnemonic that says from high to low, your brains will blow, and that's because if you overly correct hypernatremia and bring the sodium down too quickly, you will get swelling of the cerebral cortex. That's a different problem, but it's part of the same mnemonic because they both relate to sodium. And even though sodium correction is the classic cause of this disorder, you can rarely see it with rapid shifts of other osmolytes, meaning substances in the blood that raise or lower the osmolarity. This is sometimes reported with glucose. If someone has marked hypoglycemia, and you correct it too rapidly, that can also bring on this condition. So the symptoms of this disorder usually develop 2 to 6 days after rapid osmotic change, such as correcting hyponatremia too quickly. And basically what happens is you lose myelination in the pons. That's this area shown on the slide right here. This is going to lead to problems with cranial nerves, so patients develop pseudobulbar palsy. They can have dysphagia, which is difficulty swallowing. They can have dysphonia, which is difficulty speaking. You also have cortical spinal tract fibers running through the pons, and so if those demyelinate, this can lead to quadriparesis. Besides this, you can also sometimes have loss of consciousness in the patient, or sometimes patients develop a locked-in syndrome, where they're only able to blink, they aren't able to otherwise communicate because they can't move the muscles of their mouth or their arms or their legs. And once again, in the videos in the renal section where I talk about treating sodium disorders, I talk a lot more about this disorder because the risk of this condition is mostly associated with correcting hyponatremia too rapidly. And that concludes our module on demyelinating diseases.